Nivas for arranging this course with me. And the second speaker will be myself, Dr. Mohammed Al-Ashhab, Dean of Banna Faculty of Medicine. Professor Sernivas, may you introduce, please, Professor Bandi?
Thank you very much, sir. As always, I would like to thank the Indian Orthopedic Association, Egyptian Orthopedic Association, Professor Al-Ashhab in particular for this opportunity. Good evening, everybody, and greetings to all the Indian orthopedic surgeons for the Bone and Joint Week starting this week. Today's speaker is Mr. Radhakant Pandey. He's a consultant trauma and orthopedic surgeon from University Hospitals of Leicester, United Kingdom. He's associated with BOA, BES, BIOS, IOA, CESI, World Orthopedic Concern, and Girdlestone Orthopedic Society, Oxford, UK. So the prizes and medals, he has been awarded the James Turner Traveling Prize in 97-98 to visit Austin Moore Orthopedic Clinic at Columbia. Norman Roberts Medal 1997 from the University of Liverpool for the best thesis submitted for MCH Ortho, and the British Orthopedic Association ASEAN Traveling Fellowship for the year 2007 when he visited and lectured various Asian countries. He was also awarded the Best Senior Traveling Fellowship 2009-2010 when he visited Dr. Gary Gartzman in Houston, Texas, and Dr. Tom Norris in San Francisco, USA. He was awarded the Best CPD Fellowship to present paper at the International Congress of Shoulder and Elbow Surgery in Argentina. And he was also awarded the Best Trainer of the Year 2016-2017 for the Leicester Deanery in the University of Leicester. He has published over 50 peer-reviewed publications with over 1,300 citations and over 50 invited international talks about shoulder-related problems. And he has demonstrated live surgeries in India and Nepal, teaching arthroscopic shoulder surgery and shoulder arthroplasty. He's head of the elective orthopedic surgery and head of trauma at the University Hospitals of Leicester, which is one of the largest departments in the UK. He served these in 2015, 2018, and 2006 to 2009. He was also one of the conveners of the famous Leicester Shoulder Trauma Update UK, which is a yearly symposium with international speakers and is conducted in UK and internationally. He's examiner for the Royal College of Intercollegiate Board Examination for FRCS Orthopedics since 2010, and also international examiner for FRCS Ortho in Dubai and Malta. He's a member of committee with which writes oral and clinical questions for FRCS orthopedic exams. And he's a member of education committee of BES and faculty at the shoulder revalidation sessions at the BOA conferences. He's also faculty of BES instructional course in Harrogate 2019, clinical teacher of Leicester Medical School since 2001, and clinical supervisor since 2001, training PG trainees in trauma and orthopedics. He has extensive experience in shoulder surgery, shoulder and elbow surgery. His talk today will be current concepts in the management of proximal humeral fractures. Thank you very much for accepting the invite, Mr. Pandey. Please go ahead with the presentation. Thank you.
Okay, so shall I share again?
Yes, please.
Okay, can you see my slide?
Yes.
Okay, so let me start. Thank you very much, Professor Mohammed Al-Ashhab and Srinivas Kamawati. It is indeed an honor to address fellow Egyptian orthopedic surgeons. But today I'll talk about the current concepts in the management of proximal humeral fractures. Is the audio okay?
Yes.
Is it okay, Professor?
Yes, sir. Yes,
okay.
Sir.
Right. So if you look at that, there is this increasing trends of in operating proximal humeral fractures. You look at this X-ray, you will say, yeah, that's a very well fixed proximal humeral fracture. And everything looks pretty fine. But this patient is not happy because the movements are only 50% of normal, and she still has pain and stiffness in her shoulder. So just because you get a good X-ray doesn't mean that you get a good functional outcome. Whereas if you look at this fracture, this was put on my list for surgery, and I said, talk to the lady and said, well, let's see what happens. So why not we treat this non-operatively? She was also very nervous about surgery, so we treated this non-operatively. And in about 4 or 5 months' time, this healed. And if you look at this patient, he's got very good function, and he was very happy. So what I'm trying to say is a little bit of malunion in the proximal humerus is not such a bad, it doesn't necessarily lead to bad outcomes. And just because you get a perfect X-ray after doing a lot of beautiful operation doesn't necessarily mean that you will get a good outcome. So beware, surgical treatment is being increasingly used with increased cost in shoulder fractures. And there's a good Cochrane review found that surgery for displaced fracture of the proximal humerus may not result in better outcomes than non-surgical management. And I think that's lesson number 1 today. There is this PROFER trial, and I think it's an important trial, and everybody should get this message very clear. It does not say you don't operate. So if you see a humeral shaft fracture, which you obviously feels an operation, you do an operation. And the sum of them, you will feel, oh, this doesn't need an operation, you don't do an operation. But there'll be some X-rays, every day you will see them, and you'll think, whether I should operate or not operate. Those ones, they found that if you did not operate, you did as well as whether you operated. So if you're unsure whether this patient would do better with operation or better with non-operation, then you do not operate, and you will find that they all do as well as with surgery. This was a randomized control trial. And I think this is an extremely important paper which gives this message loud and clear that a lot of proximal humeral fractures, which we operate, didn't need the operation. They would have done as well had we not operated on them. And if you look at the Oxford Shoulder Score in operated and non-operative group at 2 and 5 years, you'll find at 2 and 5 years, the results are almost equal. But we are not saying you do not do any surgery on proximal humeral fracture. It's just the ones which you feel are not too bad, like these ones. So these fractures, the fracture, it looks displaced, but they are roughly reasonable position. So you can treat them non-surgically. Some degree of malunion is very well tolerated by the shoulder. It's called acceptable malunion. And elderly especially, they tolerate them very well, and non-operative management is quite successful in proximal humeral fractures. But obviously we are surgeons, we need to fix fractures. So if you decide to fix fractures, the very most important things, you should have good X-rays, AP, and an orthogonal view, not just one view. You should get an axillary of some sort. You should have CT scans, and you should do 3D CT reconstructions, because to get an adequate picture of the fracture, these things are absolutely crucial. You need to ask yourself, can I make this fracture look better after an operation? And if I do make it look better, will it translate into better functional? You need to look at the bone quality, because if it's an osteoporotic fracture, maybe your surgery may not be successful. You also need to look at the patient's functional level. I mean, some elderly patients, they don't want a lot. They're not going to throw the javelin or play volleyball or basketball. So if you can meet their functional need by something less, then I think it should be tried. You should also ask yourself, what happens if it fails? If my surgery fails, do I have a good options to salvage the problems? Also ask yourself, do I have the necessary skills to deal with complications of this fracture? Maybe someone in your town can do a better job. Refer it to them. So do no harm. That's the principle we all follow. Age is an important factor. Same fracture in a 30-year-old will be treated differently to a fracture in a 75-year-old. So same fracture in two different age groups, you will treat them differently. One you may want to operate, another one you may not want to operate. Even if you want to operate, you may want to replace rather than fix because their bone is not adequate to have fixation. So if you have a fracture which is off-ended, displaced tuberosity, significant head varus, fracture dislocation, head split, you will operate on them. They are fit, they are mentally well, they will be able to do the physio, and their nerve function is normal. You will not operate on patients where the displacement is not too bad or the patient is unfit and there is some dementia, there's lack of commitment to physio, and there is nerve injury. You have to be very careful whether you want to operate on these fractures or not. So why am I cautioning against operations? I'm not saying you don't do operation. You just have to choose the right patient at the right time and the right surgeon to do the operation, because shoulder fractures, fixation can lead to high rate of complications. Locking plate, you can get screw penetration, malunion, cuff failure, metalwork problems, requires extensive soft tissue dissection, leading to avian and post-operative stiffness. Metalwork removal is difficult in these things. And once it fails, secondary arthroplasty is also difficult and leads to poorer outcomes. Whatever fixation method you use, the most important is the greater tuberosity. That has to heal in the right place. Otherwise, you will not get a good outcome. So management of greater tuberosity is the most important thing in proximal humeral fracture fixation, whether you're nailing them, you're plating them, or you're doing some other technique. Everybody has seen or has got a collection of these x-rays. If you've been in practice as long as I have been, you will see penetrate screws, broken plates, all sorts of things. And these you don't see in the conferences. In conferences, you will see all great results. So it's important to understand that proximal humeral fracture fixation is a challenging procedure and leads to a lot of failures too. And a lot of the times I sit and try and salvage these kind of failures. So if you do want to operate in, say, 2 or 3 part fracture, what are the possible means available? So these, I mean, you have newer proximal humeral nails, and you can have, I'm sure all of you have done a plating of the proximal humerus, but try, I think the newer proximal humeral nailing are becoming more and more popular, and they are now as good. The results are as good as locking plate. We in Leicester use a lot of percutaneous techniques where we don't do a lot of soft tissue dissection, and I'll show you a few examples of that. So if you do a mini open reduction and percutaneous screw fixation, you do very little soft tissue dissection, hence it's an attractive option because it maintains the blood supply. And it's very easy to remove the metalwork. And the screws don't penetrate because they're not locked into the plate. They don't penetrate into the articular surface, they back out. So you don't have to take them out under a gel anesthetic. And we put the screws in a set pattern. So it has got a good hold, even in a slightly osteoporotic bone. So I'll show you some examples. Like this is a 3-part fracture. You can see the similar x-ray. It's valgus impacted, the humeral, the articular surface is facing up. So we make a small hole and put this McDonald's inside and push the head up. So that was in valgus impacted. Now we put it in the right place. We push the tuberosity down and we fix it with one wire. The wire is into the very good bone in tuberosity, very good bone in calca. And then it's got a good platform on which the head sits on. And then we put another wire from the tuberosity to the head and another wire from the humeral shaft into the head. So each fragment has got some fixation. Now these wires are substituted by cannulated screws. The screws go on top of it. That's the real case, and that's, I'm showing you a plastic bone. So you see, it's all, the head has been reduced well with very small incisions, no big dissections, no disruption of the blood supply. And this is the same case after, that was the original X-ray that has been like this after 1 year. It has now healed and the patient has had good function, and we have not done any gross damage to the blood supply. We've done it many times. This fracture has been treated the same way. This fracture has been same way. Very small cuts, almost percutaneous. Very complex fractures can also be treated. It requires meticulous putting each fragment in the right place and fixing it. We've published this in JBJS. We've also done fracture dislocations that have been published in shoulder and elbow. So this is a small video which you can see what we do. So that's a very displaced fracture. And we can reduce it using various instrumentation. So you use a pennybacker to push the humeral head in the right place, and then we put temporary wires to hold things. This is all done percutaneous under X-ray. See, we hold it, and then you see the tuberosity is still quite high. So we pull it down. So now you see the whole thing is reduced reasonably well, and we push another wire, hold everything temporarily, and then put all these wires are substituted by screws. So we're not leaving wires sticking out of the skin. All these wires, they are substituted by screw, and you can get a reasonably good appearance. You're not getting the best reduction, but you're not doing any damage to the soft tissue. You're getting acceptable reduction, and this will lead to good outcomes. Again, this is a fracture dislocation treated with percutaneous screws. No big dissections. Fracture dislocation, anterior fracture dislocation, intra picture reduced, fixed with wires, and then substituted by screws. And this is after 1 year. So you can do a lot with just minimal fixation and minimal soft tissue dissection. Now coming to locking plates. Locking plates are very, very exacting technique. And I'm sure all of you have done locking plates, and very common, is still the most commonest fixation device we use for proximal humeral fracture. You have to make sure the plate is about 0.5 centimeter below the tuberosity. This is very well reduced, the medial calcar. Even if you don't reduce it, the shaft have to be displaced medially. You should never have the shaft laterally, otherwise the head will fall down. Medial cortex has to be reduced anatomically, and this screw here has to be crucial because that goes from here. This is the calcar screw. This, if you don't get it properly, then you're likely that this fixation may fail. The humeral head should never be fixed in varus position. So this is not an easy operation. Everybody feels that, oh, I can just put a plate with screws. It requires a lot of meticulous planning and a lot of soft tissue dissection. Again, the key here is a tuberosity management. You can put a very good fixation plate, but if you have not fixed your tuberosities properly, all your fixation will fail. However good the X-rays look, the tuberosities need to heal in the right place. It's still the most common. Sometimes I use a fibula strut graft intramedullary that gives a nice stability. And again, you see this screw here could have been a bit longer, but it's going through the fibula. So fibula is good. But I tell you again, this is a very difficult operation. It should be done carefully because if you fail here, it's disastrous for the patient. If this metalwork fails, it is disastrous. So you have to get it right the first time. Always do an intraoperative X-ray when you start putting 1 or 2 screws. Hold it there, check under X-ray before you start putting all the screws. Very important. I will avoid a locking plate in elderly osteoporotic bones because many times they fail. There are other better options available. If I have to fix, I will do simple percutaneous technique rather than putting a lot of metal work. And if you have to put it, I would use an intramedullary fibula graft. This is again nicely fixed plate. You can see it's about 0.5 centimeter below there. There is a Calca screw. Again, it's a good thing. It bails you out of very complicated situations. Now, this is the new kid on the block, the nailing, which is, I think, very, very, these are newer nails. Previously, the nails were slightly curved. These are straight nails, and they have changed the entry point. It is not around the tuberosity anymore. It's not in the tendon rotator cuff, because that was a problem with nailing. It was to damage the rotator cuff. Now it's put medially in the muscle. The supraspinatus muscle is cut, not the tendon. We don't cut the tendon. It's very medial. It's almost in the articular surface. And this nail goes straight down. And that way you don't damage the rotator cuff so much. Again, you see, this can be plated very well, but this can be nailed also with a very small cut. And you see the entry point is almost in the articular surface. And this is a straight nail. And again, there are many examples. In fact, we are doing more nails now for proximal humeral fracture than locking plates. Because we find that the rotator cuff problems are minimal, and it's a much quicker and less damage to the soft tissue structures around the proximal humerus. Again, this is also done. So a systemic review of 3,400 humeral fractures fixed with locking plates showed quite significant complications: screw penetration, impingements, varus collapse, avascular, and reoperation rate was 13% in one paper. But the reoperation, where they compared nailing with plating, the reoperation rate in plating was about 30%, whereas in nailing it was about 19%. So the nailing seemed to, the newer nails, these are not old nails, the newer straight nails with a correct entry point have lower reoperation rate than locking plates, which was very surprising to me. So I think the locking plates are taking, so the nailing is now taking over the locking plates, but locking plates still remains a very popular method. Okay, now this is all fixation. So now we talk about arthroplasty. Now this is an important aspect, treatment option, especially for proximal humeral fractures. So when do you do arthroplasty for these fractures? Generally, they are done in elderly patients who have head splitting fracture, very displaced 4-part fractures with poor bone quality, 3 or 4-part fracture dislocations in elderly patients. But now you will find 50, 60-year-old having fracture dislocations, especially with all these adrenaline junkies doing all sorts of very, very high impact sports. And if you feel the fracture cannot be fixed or the fracture fails, sometimes trauma sequelae like avascular necrosis and complex non-union, you have to think about arthroplasty. Now, this is the biggest dilemma these days: hemiarthroplasty or reverse shoulder arthroplasty. So in United States, they've almost given up hemiarthroplasty. They don't do hemiarthroplasty. They just go straight for reverse shoulder arthroplasty. In United Kingdom, we are a bit more conservative. We still use hemiarthroplasties. But the very important thing in hemiarthroplasty, the tuberosities have to heal, just like in fixation. The tuberosities don't heal, your hemiarthroplasty will fail. So we do hemiarthroplasty if we feel the tuberosity is one chunk, large chunk of tuberosity is there, which can be fixed, then we use the hemi. Otherwise, we will do a reverse shoulder. So the tuberosity is the key in deciding whether we can get away with hemi. And hemis are nowadays generally done for younger patients, not for because you'd use a platform system, like people in their 60s, 50s or 60s. We use a platform system. We do a hemi. We know it will fail sooner or later. We can change it to a reverse and we don't have to take the prosthesis out. We just change the top and you can convert into a reverse. The problem with hemi, it's a very good option. If the tuberosity is intact and it heals, it gives very good results, but it is unreliable. We don't know which ones will give good results, which one will not give so good a result. And that is the problem. So it's largely, its use is going down, and relatively young patients, we still use it. But remember, although our reverse shoulder arthroplasty is a very, very attractive option, remember it's a complex operation, and it's expensive, and it has slightly more complications. So you have to learn, especially our younger friends in Egypt, that you have to learn it properly before you start doing reverse arthroplasty. You don't go and watch a video and start doing reverse shoulder arthroplasty in trauma patients. You should go and work with somebody senior, see him do one under his supervision, and then you probably do a better job. So it's very important to learn before you start using all these arthroplasty techniques. What are the indications for reverse shoulder arthroplasty? I use it for patients over 65, but in America, they're using it for 50, 52. Even in UK, they've started doing them. The key thing is, can you fix it or not? If you can't, then you think of arthroplasty. Head split fracture and failure of fixation. Like if you put a plate and it's failed, you haven't got many options left. You may have to go and do an arthroplasty. But rarely, if you fail, maybe you can refix, but most of the times you have to resort to arthroplasty if your fixation fails. That is why fixation is a very complex operation and should be done judiciously, because if it fails, it's a disaster for the patient. A failed hemiarthroplasty, also we do a reverse. What are the contraindications for reverse shoulder arthroplasty? If there is a deltoid deficiency, you will not do a reverse shoulder arthroplasty. If there is an axillary nerve function, which obviously affects the deltoid, you can't do a reverse shoulder arthroplasty, because reverse shoulder arthroplasty entirely relies on deltoid. Infection and some very high demand patients who are young, sometimes you may have to think whether they will comply with the restrictions of a reverse shoulder arthroplasty or not. In elderly, all of them will have rotator cuff dysfunction, and tuberosity fixation is difficult. Then I think a reverse shoulder arthroplasty will give you the best result. And recent meta-analysis done, reverse shoulder arthroplasties are doing well in every age group, in every fracture. So it seems everybody wants to do reverse shoulder arthroplasty, but I will put some caution here. There are other means of treating, and we should try them. There is an explosion of reverse shoulder arthroplasty in the West, and I would caution you against it. Be judicious. Recently they found that, like, unlike in hemiarthroplasty, where you have to repair the tuberosities very well, and its entire success depends on tuberosity healing. That is not so in reverse shoulder arthroplasty, where you also repair the tuberosities, but even if the tuberosities don't heal, they still are doing very well, which is very surprising in trauma situation. So even if your tuberosity, if you just reattach the tuberosities, but if they heal, if the tuberosities heal in a reverse shoulder arthroplasty, they do very well because they'll have rotations and they are more stable. But even if they don't heal, don't worry, they're functionally still very good. So as I said, reverse shoulder arthroplasty, that biggest advantage it has over the hemiarthroplasty, that it's reliable. You can tell a patient that you will get 90 degrees of forward elevation, some external rotation in most cases. Whereas in hemiarthroplasty, you can't say that. If the tuberosity heals, they'll do better than a reverse shoulder arthroplasty some instances. But if the tuberosities don't heal, they are significantly worse. And that is the problem, the unreliability of hemi. And it's a very versatile thing, reverse shoulder arthroplasty. If you fix and it fails, you can do a reverse, and they still do well. 79% of these patients do well, even after a failure of fixation. So I think things are going in the direction of reverse shoulder arthroplasty. Even non-union salvage in an elderly person, if the tuberosities are not there, or you feel the rotator cuff is not functional very well, you will end up doing a reverse shoulder arthroplasty with reliably good, reasonable function and pain control. These days, we are using them in old unreduced locked dislocations. This is a 60-year-old who has this dislocation, fracture dislocation, 8 months old. And when you go inside, you see that the articular surface is not very good. We've done a reverse shoulder arthroplasty and he's done very well. But again, I'm extending the indications for a reverse shoulder arthroplasty. I know some great surgeons would try and just do a reduction and see and put a bone block and see if it works. But sometimes you will have to keep arthroplasty on the shelf because if that operation doesn't work, you may have to do an arthroplasty. It is important to know what the literature says. If you look at in 2007, for all the reverse shoulder arthroplasty for trauma, the complication rate was almost 28%. But as we have progressed, if you come down to last paper in 2017, the complication rate has gone down to 9%. And recently there are meta-analysis published for reverse shoulder arthroplasty. The complication rate is as good, as low as any other procedure, like 3 or 4%. So obviously we are getting better doing reverse shoulder arthroplasty in trauma. People are getting more experience. So I implore you that you must get good training in reverse shoulder arthroplasty. If you are going to do trauma, dealing with proximal humeral fracture, you should be able to do everything. You should be able to do a percutaneous spinning. You should be able to do a plating. You should be able to do a nailing. You should be able to do an hemi. And you should be able to do a reverse shoulder arthroplasty. You cannot be a one-trick pony. You should know all the tricks in the trade. So we are getting better. And now the outcomes are compared. So in elderly patient, now elderly patient, you may say, who is an elderly patient? I would say anybody above 65. But you may defer it. Obviously, some 70-year-old is extremely fit. Some 65-year-old is not so fit. So you just look at them. And they have said that if you do an open reduction internal fixation with plate or nail and compare that to reverse shoulder arthroplasty, the reverse shoulder arthroplasty does better in elderly patients. Not all, but the comparator group, they found reverse shoulder arthroplasty did better. Again, when you compare it to hemi, the reverse does better in elderly. If you do a primary reverse shoulder arthroplasty as opposed to a salvage reverse arthroplasty, that means if you see a fracture and you do a reverse shoulder arthroplasty in the beginning as your first line of treatment, they do better compared to somebody who's had a fixation first and that has failed and then you do a reverse. So if you want to do a reverse shoulder arthroplasty in a fracture scenario in an elderly patient, do it earlier rather than later. But reverse shoulder arthroplasty is not the answer for everything. It has got complications and you have nerve injury, fractures, periprosthetic fracture. Now the next epidemic in the West is periprosthetic fracture around a reverse shoulder. So we do have problems with reverse shoulder arthroplasty too, but it's looking good. And you can see here a couple of my complications, dislocation completely, because if someone has got a very poor bone, it all can fall apart. So in conclusion, I would say function is most important. Proximal humeral fracture is a life-changing event. I have not till date seen a proximal humeral fracture fixed and they return back to 100% as how they were. They always are slightly less range of movement, power. So it's a life-changing injury, especially in the elderly. If you want to operate, you can operate if they're very displaced. If they're not very displaced, they're somewhere around. And even if they're displaced in the elderly, they will do well without surgery. So ProFAR is very important. And if you want to do surgery, you have to get it right the first time. There are no second chances in proximal humeral fractures. You have to have a good patient who's anesthetically fit, mentally fit, not having osteoporotic bone, and physiologically, he will do physiotherapy. Physiotherapy is absolutely crucial in any form of fixation you do. It has to be a shared decision. You have to discuss with the patient. You have to give the options to the patient. And you have to individualize what kind of treatment you will do for the patient based on the patient characteristics and the fracture characteristics. You can't have one solution for every prosthetic, every periproximal humeral fracture, because the same fracture in a 25-year-old will demand different treatment than a 75-year-old. So non-operative management is very important. You should try them in many situations. Younger patients with significantly displaced fracture, you can try surgical fixation. Now you can use percutaneous fixation, locking plate, IM nail. All three of them are very good solutions, and all three of them pretty good results in the right patient done by the right surgeon. If the proximal humeral fracture is unreconstructable, you cannot fix, then you have to think about arthroplasty. Be cautious using hemiarthroplasty. I will do a hemiarthroplasty if the tuberosity is one large chunk which I can fix and I can be assured that the tuberosity is likely to heal. Otherwise, RSA, that is the reverse shoulder arthroplasty, is becoming the mainstay of management in unreconstructable fractures, or especially in the older patients. And also in salvage situation, the important thing is they give more reliable outcomes, but it is technically demanding surgery, and surgeon experience is crucial as complication rate can be high. And to improve the outcomes, you need to have surgeon who's well-trained, absolutely crucial. So thank you. So shall we just run through some cases quickly?
Yes, please, sir.
Okay. So I don't know if somebody wants to take, so now I have, for example, this is a 41-year-old lady, fall in a kitchen, diabetic, lives alone. So that's the fracture. So because we don't have many students, then I think I will just think. So this is a fracture. It is pretty displaced. This is a young patient, 41, is young these days. If you want to treat this non-operatively, you are absolutely fine because there is 25% contact. You can give it a chance if you want to treat this non-operatively. So I discussed with the patient. I told you can treat this non-operatively, but the chances are that there is a higher risk of non-union, but it can unite. So if you want to leave it and see how we'll X-ray. When I say non-operative, it doesn't mean you just discharge them. Non-operative sometimes is more difficult because you have to see them at week 1, do another X-ray. You have to do a week 2, you do another X-ray. And also you don't know when to start mobilizing them. So I mobilize them early. By 2 weeks, if they need to start gentle mobilization, 3 to 4 weeks, they can start passive exercises. So I gave her the options of doing a operative fixation, and I gave her the advantages and disadvantages of both of them. I discussed both non-operative and operative, and she looked at it and said, I think I don't want to carry on thinking it may unite. I want a definitive answer. So we did fix it with a plate. And she did very well, but I did offer her non-operative. We could have nailed it too. Don't ask me, why did I not nail it? Why did I plate it? It's just on that day, I had to show my registrar how to do a locking plate. So we did a locking plate. We could have nailed it also. It would have done as well because it's almost a 2-part fracture. Okay, that's case 1. This is case 2, 72-year-old man, fell at home, slippery, known diabetic, but well controlled. So have a look at the X-ray. So every proximal humeral fracture, I want to do an operation, I will get a CT scan and a 3D reconstruction. You must do that. Otherwise, there will be surprises in the theater. So this is a 3D CT. We thought, well, we were still not sure, but I think that the head may be broken, the split. So we thought, okay, we'll go with an idea to fix, but if we feel it cannot be fixed, we will keep arthroplasty on the shelf. Because he's 72, we went in, and you see the head is in 3 pieces. So, but the tuberosity was good. So we did a hemiarthroplasty. You see that nice, big, chunky tuberosity. We fixed it to the shelf, and this patient did tuberosity, went on to heal. He had reasonably good function. If the tuberosity was not good, I would have done a reverse shoulder arthroplasty for him. So that's example number 2. 3, again, slipped on ice, non-dominant shoulder, no nerve injury, no major problems. He's a fit 72-year-old. That's the fracture. So the problems here are, that's the 3D CT. The head is very displaced, as you can see. There is a risk with reconstruction. You may try reconstruction, putting a locking plate, but the chances of failure is high. Chances of avascular necrosis is high. So either we do nothing, but if I am going to do fix, I'm going to fix it. You can try it, but the risk of failure is very high. When it fails, it's disastrous. So we did a reverse shoulder arthroplasty in a 72-year-old. This person will do very well. We can reliably tell them they can get 90, 100 degrees of forward elevation, some external rotation, and he will start, his function will start next day. We'll start moving as soon as he can. And no fixation can give you that kind of guarantee. Okay, this is case number 4. 84-year-old, independent, hypertension is controlled, tripped in a garden. That's the X-ray. Now you'll say that is a very displaced fracture, right? So everybody's thinking of doing a reverse shoulder arthroplasty or a hemiarthroplasty. So I told her that this is very displaced, it will not be good function. She said, no, doctor, I don't want an operation. She did not want an operation. What do you do? I said, fine, we will treat you non-operatively. This fracture has healed, all in wrong position. The tuberosity is wrong, the head is wrong, the shaft is wrong. But look at this patient. She has, I cannot give her better function with any operation. She's got very good function. She's no pain. She's smiling. And she says, see, you wanted to do an operation on me. Look, I am doing everything. So this, till this day, I've been doing shoulder surgery almost 30 years now. Proximal humeral fractures always surprises me. Okay. One more case. So this is very important. You can say, you can see that this looks very horrible fracture. However, the head is facing in the right direction. The shaft is under the head. The tuberosity is roughly in the right place, not very far. It's comminuted. Can I operate on this and make it look better? Yes, the X-ray will look better, but the function may not be as well. So I said, listen, and the tuberosity is there, the head is there, the shaft is here. Not everything is nearby, it's not very far. So I gave him the option of non-operative and operative. Operative, I said, well, we could fix it or we could replace it. And this gentleman says, nah, no, doctor, I don't want an operation. So we said, okay, this is a fracture which has now healed. And it is healed completely in 1 year. And this is the man. He's got this so much function, no pain, and he's very happy. He goes bowling and goes walking, and he climbs mountains, no problems. So so what I was trying to show is that sometimes even with what X-ray looks bad, non-operative works very well. And if you want to fix a fracture, be certain that you are going to give the patient one operation only, and that will make him better. And if you're not sure, then an arthroplasty, especially in elderly patients, and most of these fractures are in elderly. Thank you very much. I hope that was useful.
Thank you so much, Mr. Pandey, for this very interesting presentation. Thank you so much, sir. Professor Sernibez.
Thank you very much, Mr. Pandey. That was
okay. So,
Dr. Srinivas, you are muted, sir.
Dr.
Srinivas?
Yeah, I think, can you hear me now?
Yes.
Yes, sir.
Yes.
We can hear you.
Yeah. So I'll stop sharing.
Yes.
Yes, it stopped already, sir.
Stopped.
Oh, okay.
Yes. Thank you very much, Mr. Pandey. That was very comprehensive and with illustrative examples. We have about 3 questions here from the viewers. One, Dr. Sanjay Srivastava. He says COVID to be ruled out in case of avian of humeral head. I'm not sure what exactly the question is. So,
COVID. Sorry, can I?
Yes, he probably says, should we rule out COVID in case of avian of humeral head? I think since we have passed the COVID time now, maybe steroid administration of steroid, and how frequently do you see avian of humeral head with associated fractures in post-COVID times?
I don't think it's related to COVID so much as the characteristics of the fracture itself. There is a slight difference between avian of the humeral head as compared to avian of the femoral head. The hip avian is very badly tolerated, whereas avian of humerus is reasonably well tolerated. So even if you have half the head dead, patient can still work reasonably well. It depends on what age they are. So avian is a problem, but not as big a problem as in the femur. And sometimes you have to do arthroplasty, but I don't think the avian is so, I mean, I may be wrong. In 10 years' time, you may prove that the COVID caused the avian, but at the moment, there is no evidence to suggest that COVID is causing avian. It's probably the fracture pattern is causing the avian, or the surgeon is making avian by doing operations, which are not necessary, or doing badly, or stripping off a lot of the blood supply. So do no harm. If you're not going to do a good operation, non-operative works very well.
The next question is, if I'm from Dr. Mozimul, he asks, if I'm doubtful of tuberosity healing in RSA, is it better to excise them intraoperatively rather than keeping them?
No, don't excise them. You repair them. Once you repair it to the stem, at least it will provide you with some stability in the initial period. If it doesn't heal, then bad luck. But that doesn't cause that the outcome to be bad. But excising them is not right, because at least it provides stability. It may or may not heal, and it's very difficult to say intraoperatively whether this tuberosity will heal or not. The ones you feel may not heal may heal, or once you feel will heal may not heal. So excising it will be a bad idea. I would repair it anyway.
Again, another question. What is the outcome of PROFER-2 study?
It's still going on. Once we, it's an interesting study. We'll see what happens.
Question from Dr. Sharif Nagar. Patient 20 years old with proximal humerus fracture fixed by Phylos plate 6 months ago. Comes to him for 1 week with nerve root injury C5, 6, C8, T1. How to manage?
So what is the outcome now? What is the problem in the shoulder?
He just mentions nerve root injury.
Sorry, I'm not able to hear that.
The patient is post-op Phylos plating 6 months ago.
Yeah.
And, he presents 1 week. From 1 week, he says. So probably the symptoms are 1 week. Not sure. With nerve root injury C5, 6, C8, T1.
So this happened because of surgery or because of the injury, or it's a new thing?
Not sure, actually. I think we need more information on the clinical picture. It will be useful.
Yeah. I mean, obviously, this is quite a dreadful problem now. So it requires a lot more workup. We need to know whether this happened post-surgery, post-injury, and what is the deficit now. I mean, I would have, if this was post-injury, that brachial plexus kind of injury, then I would have addressed that much earlier. 6 months, I would speak to somebody who has specialist interest in nerve injuries. This is a complex problem. In England, we would send it to a nerve center where they'll do various muscle transfers, nerve transfer. But we need to be clear, when did this injury happen? Whether the surgeon caused it or the injury caused it, or it's a new problem.
He just messaged the injury was initially at the time of injury. The nerve injury was at the time of injury. So 6 months old.
Right. Now, this needed to have been sorted at the same time, earlier the better. Any nerve injury you find, that needs to be addressed by a specialist as soon as possible. Don't wait for 6 months. It will only get worse.
So the question from me, actually, if you don't mind, since this being our Bone and Joint Week, and the theme of this year for Indian Orthopedic Association is a strong bone and stronger nation, and proximal humeral fractures are associated with osteoporosis, how do you investigate and manage osteoporosis with these fractures?
So we treat them, this one, like any wrist fracture or fracture neck of femur or an osteoporotic. So we get them to a metabolic bone specialist. So we are all specialists in our field. So I'm not very good by starting a HRT for women or doing bisphosphonates for men. We have people, but we send them for a DEXA scan. We do some calcium and vitamin D basic levels. And if they are osteoporotic, we do use the WHO guidelines and treat that. So this is an osteoporotic fracture, especially in elderly patients. Yes.
And what is your opinion on the role of some of these implants like Just Unique and Da Vinci cage or Covent cage? How useful are they in fixation of these fractures?
Well, as I said, operations are operations, and Just Unique, again, it's a very unique implant, but it has been used by very few surgeons. It originated in France. So there is one surgeon in France and there are few others who use it. There are few people who use it in India quite extensively, and they have said good results. I don't have personal experience with this, and I personally don't see the big advantage of using the Unique and the other implants. But this is my personal opinion. But these implants have not caught on by everybody, not like reverse shoulder arthroplasty or locking plates, which everybody is doing. But these are very specific, and I personally haven't got experience, and I personally feel they are not extremely popular.
How do you manage
Mohammed Al-Ashab has got his hand up.
Oh, yes. Yes, sir. Please go ahead.
Yeah. Go ahead, Dr. Srinivas. After you, sir.
How do you manage biceps tendon in these fractures in elderly compared to younger patients? Do you sacrifice?
If it's coming in my way, I'll do a tenodesis. And in arthroplasty, I always do a tenodesis. Fixation, but it is a very important, it's like a lighthouse for a boat. So when you go your operation, if you find the biceps tendon, you should rejoice, because now you know what is what. So anything in front of it is the lesser tuberosity, anything behind that is great tuberosity. I feel very disoriented if I don't find the biceps tendon. After you found it, you can cut it and reattach it somewhere else.
Professor El-Ashhab, please go ahead.
Yes, please, sir. Mr. Bandi, I want to ask you a question, sir. In case of comminuted fractures, proximal humeral comminuted fractures, do you use routinely the 3D printing to preoperative evaluate the fracture and proper your way of management?
We do use it sometimes, not routinely because it's expensive in England. But if you find it's extremely broken, then yes, you can do 3D printing also, but it is not something we do routinely. We do 3D reconstruction almost every fracture, because if you do a CT scan, it's very easy to do a 3D reconstruction. But we do 3D printing more now than we did 20 years ago, because that technology is available. I don't know how much it helps us, but sometimes it's good to have new toys.
Any other questions, Dr. Srinivas?
No more have been asked, actually.
Okay.
Mr. Pandey, any tips on the placement of the plate, Phylos plate in a fractured, in a multi-fragmented proximal femur fracture? Or stabilizing the head, especially when you place the plate, exact position of the plate.
Yeah, so the important thing, as I said, in the plating is the tuberosity management. It's not the place so much you put it. I don't mind where you put the plate, whether you put, some people put it anteriorly, laterally. That's the tuberosity has to be fixed properly. Now, if you are putting a plate, you try and go as laterally as you can under the deltoid. Make sure it's slightly below the tuberosity, not very high. And you reduce the medial calca very well. And if you are not able to reduce the medial calca very well, you can medialize the shaft a bit, but never lateralize it. And then you put your plate, and I say the first 2 or 3 screws, you do it under X-ray control. You must have X-ray in theater. However good you are. You may think you are the world's best plater in the world. I will still say you have to have the X-ray. So, and if you can put a calca screw, as I showed, that is again a very an added bonus. Sometimes I use a fibula graft in the middle, and that is like you put it in the humeral head and it holds it there. And if it's very comminuted, as you said, it's very comminuted, I will question whether I should be plating this or not. You know, the majority, there are some papers which report 40% complication rate in 4-part fractures. 40%. That's almost 1 in 2. So locking plate was very, very popular, and suddenly everybody was doing for every fracture. It is not my favorite implant anymore, because the number of complications I see is just staggering. For a 2-part fracture, no problem. 3-part, not so bad. 4-part, maybe I'm not a very good surgeon, but in my hands, the complication rate is a bit high in 4-part fracture, especially in plating. And again, it is not where you put the plate, how you put it, is how you manage the tuberosities. You make the tuberosities. Your beautiful done plating, if the tuberosities don't heal, you can say bye-bye to that shoulder.
How about suturing of these fractures, 2-part, 3-part fractures, 4-part fractures?
Again, every implant known to an orthopedic surgeon, every implant known to an orthopedic surgeon has been used in proximal humeral fracture. It's all about the right patient, the right technique, and getting the tuberosities to heal. Whenever I plate a proximal humeral fracture, I always suture the tuberosities. Even if I put a screw through that, I put an Ethibond, and every plate has got a hole for sutures to go in, and you can tie the tuberosities. So sutures also are okay, but again, it's not for every fracture. As I said, as a shoulder surgeon, you need to know all the tricks.
Thank you very much, Mr. Pandey.
Okay.
Thank you so much, Mr. Bandi, for this very interesting presentation.
Okay,
It was a pleasure for us, sir.
No, thank you very much. I will be listening to your talk. I'm just going to drive for 10 minutes, but I'm listening to your talk.
Thank you so much, sir.
Very carefully.
Thank you, sir. Thank you so much, sir.
Okay, you take care.
Thank you, sir.
Let me just transfer this thing to the phone now. You can start. Yes,
sir, please. It's an honor for me to make a presentation after an eminent speaker like Mr. Bandi. Thank you, sir. Can I share my screen?
Yes, please do.
I think Professor El-Ashhab does not need introduction, at least in the Egyptian and Arab world, actually. So,
no, sir. Thank you so much. It's an honor for me to be a speaker after Mr. Bandi. Because of the importance of this topic, the proximal humeral fractures, I will also, my talk also will be about the proximal humeral fractures. I'm sorry. This is not the P1. Just one moment. It's clear, sir?
I cannot see the PowerPoint, sir.
I can't see the slides either.
Okay, just one moment. Yes? You can see it, sir?
Yes, we can see the slide.
Yes, thank you so much.
Yes,
because of the importance of this very important topic, the proximal humeral fractures, my talk also will be about an overview of proximal humeral fractures. I think I will concentrate in my talk on the arthroplasty. Many of things we share in this topic is already illustrated in the very nice talk of Mr. Bandi, but I have another point of view. So it's my talk to my fellows in the Egyptian Fellowship Program. So I will have an overview of all the topics of the proximal humeral fractures, including the classification, the different ways of management, the radiology of the proximal humeral fractures. First of all, proximal humeral fractures account for about 10% of all fractures, being the third most common fractures in the elderly population, following hip and distal radial fractures. The patients above 60 years old represent about 70% of patients with these fractures, with obviously increased incidence in women than in men due to osteoporosis. And this is, as Mr. Bandi said, the age is the main predictive thing in managing these fractures. When I'm speaking about the bony anatomy, the proximal humerus consists of the articular surface, the humeral shaft, the greater and the lesser tuberosity. The humeral head is a segment of a severe that measures from 37 to 57 millimeters in diameter. The average of the neck shaft angle is 130, while the average of the humeral head offset from the shaft is 3 millimeter posterior and 7 millimeter medial. The most superior portion of the humeral head is typically 8 millimeter above the height of the greater tuberosity, and this is a very important indicator to measure the length during making a hemi or reverse shoulder replacement. Humeral retroversion varies widely with an average values ranging from 18 to 33 degrees. The musculatures, the supraspinatus, infraspinatus, and teres minor attached to the respective facets on the greater tuberosity. The lesser tuberosity is the site of attachment of the subscapularis. The mechanism of injury. What about the mechanism of injury? The most common mechanism is a fall on the outstretched arm in an elderly patient with osteoporotic bone. Less frequently, fractures are seen in young patients with high energy injuries and motor vehicle accidents. A rare potential mechanism is violent muscle contraction caused by electrical shock. How to assess? To have clinical assessment is required to avoid any impending pitfalls, clear history of the mechanism of injury, the patient's pre-morbid activity, and the level of expectations is important when considering the treatment options. And that's what's exactly Mr. Bandi has shown in the cases he has shown in his presentations. I have to speak with my patient. What's your expectations? The handedness, the occupational status, the hobbies, and the level of daily activities should also be taken into account. Examination of the injured limb is also of great importance for the skin tenting and impending necrosis, for the neurovascular status, for the tractional injuries to the axillary nerve and the brachial plexus, which may be present with concomitant dislocations. To image such a fracture, I have to do X-rays, anteroposterior scapular view, which is the true anteroposterior X-ray, axillary lateral view, and scapular Y view. The Valpio axillary lateral view is an alternative for the patient that cannot tolerate abducting the arm for axillary lateral. CT, of course, is very important, and three-dimensional CT is very important. So it's useful to evaluate the tuberosity displacement, the humeral head splitting, the impaction components, the degree of comminution, and any involvement of the glenoid articular surface. And of course, all of these items would have a great role in deciding my management. Magnetic resonance imaging has a limited role in acute proximal humeral fractures, and it's useful in diagnosing non-displaced greater tuberosity fractures. To understand, to go with the management and select the management, which way of management should I select? I have to understand the proximal humeral fracture classification. The most important classification in proximal humeral fractures is NIR classifications in 1970. The crux of this system is based around the bony anatomy of the proximal humerus defined by Codman in 1930. He subdivided the proximal humerus into four major areas: the humeral head superior to the anatomical neck, the lesser tuberosity, the greater tuberosity, and the displaced shaft of the humerus. So I can have a two-part fracture, three-part fracture, four-part fracture, and of course, fracture dislocation. The displacement considered significant if the fragment had moved by more than 10 millimeters or rotated through more than 45 degrees. The Moller classification, based on the importance of the blood supply to the proximal humerus, he classifies his classification. He relies on differentiating between fractures proximal and distal to the anatomical neck, and this is very important for the vascularity. The main blood supply arises from the anterior humeral circumflex artery, which feeds the arcuate artery. If this artery was to be avulsed, the viability of the head could not be maintained. Types of Moller classification: type A, extra-articular unifocal with its subtypes; type B, extra-articular bifocal; and type C, intra-articular. And this figure shows the AO classification system, which was developed in 1980, and it's mainly based on the vascularity and the affection of the vascularity of the head. In 2013, a new classification system, the Huggles system, the humeral head, greater laser and greater tuberosity, laser tuberosity and shaft. This system is based on the work of Hertel et al., which devised a system to classify the proximal humeral fractures with an attempt to predict the risk of avascular necrosis. And of course, the probability of avascular necrosis would decide my future way of management. Based on the location of the 5 possible fracture lines, there were 12 basic fracture types identified. In contrast to nerve system, a fracture fragment was considered to be present if a cortical disruption could be identified on any radiographic view. Decision-making, and this is a very important item. The decisions over which treatment modality is best suited for the favorable outcome with regards to the proximal humeral fractures are difficult and multifaceted. There are some absolute indications, so the patient will go to the operations in open fractures, vascular injuries, neurological damage, pathological fractures, 3 or 4 part fracture and fracture dislocation, and true head splitting fractures. There are, however, these are, however, the minority of cases, and up to 80% of proximal humeral fractures are undisplaced secondary to the low energy fracture. And of course, these can be managed non-operatively. I'm very happy with the cases that Mr. Banti has shown in his case presentation at the final 2 cases that was managed non-operatively with a very, very good post-management outcome. This is very important because not all the patients have to go to the operative theater to go with an internal fixation or arthroplasty. I have to think thoroughly about the non-operative management. Various options are available when it comes to surgical interventions. Minimally invasive, plating, nailing, and arthroplasty techniques have all been mentioned. Surgery is generally aimed at patients who have expectations higher than what can feasibly be achieved by conservative management. These people tend to be younger and lead more to active lives. And of course, we come again to the main predictive point and the main decision point in the management is the age of the patient. Surgery is also used to avoid or decrease risk of malunions and non-unions. The treatment options. Treatment options include, number 1, non-operative management. Number 2, closed reduction and percutaneous spinning. Number 3, open reduction and internal fixation. And number 4, shoulder arthroplasty. Non-operative management. Non-operative management is best suited for these fractures that already have a potential for union and will be amenable to an adequate outcome for each specific patient. These feet fractures are commonly those in stable configuration and with minimal displacement. Less than 30-degree varus valgus angulation of the diaphyseal shaft in relation to the humeral head. Conservative management routinely consists of 5 periods of immobilization in a sling like manner in order to obtain adequate pain control and mobilization under guidance of a physiotherapist. Of course, I don't leave the patient. Some sort of physiotherapy should be initiated by 2 weeks post-injury. Physiotherapy consists of simple pendulum movements in the early stages, progressing onto vertical wall walks when symptoms allow. The periods of non-unions, symptomatic malunions, avascular necrosis of the humeral head are the main problems in preventing a positive outcome. Now I come to the operative treatment. The primary aim of operative treatment is to restore function to the reasonable expectations of the patient. In order for this to occur, congruency must be restored between the humeral head and the shaft. And of course, healing of the tuberosities in an optimal position is a very important item. Infection, non-union, metal wheel failure, of course, are complications of the operative technique. Minimally invasive closed reduction and percutaneous fixation, as Mr. Banti has mentioned, the obvious advantage of this technique is minimal soft tissue dissection when compared to other types of operations. This decreases the risk of avascular necrosis, non-union, blood loss, post-operative pain and infection. The fracture is reduced under image guidance and held with the use of either Kirschner wires and screws, and take care of the safe and unsafe area for putting the wires and the screws. So I should have my wires and screws in the safe area to avoid injury of the axillary nerve. Sound understanding of this round anatomy is essential, as damage of the axillary nerve, cephalic vein, long head of biceps tendon, and posterior circumflex humeral artery has been previously documented. Open reduction and internal fixation, plate and screw design with multi-directional locking options can now withstand extreme pull-out forces. The anterior deltopectoral approach is still the workhorse of this operative technique. Exposure for comminuted fractures, particularly including the posterior aspect of the humeral head, can also utilize the extended transdeltoid approach. And the approach is variable according to the geometry of the fracture. And of course, as Professor Srinivas asked, the proper position of the plate depends on the geometry of the fracture and the shape of the fracture and geometry of the fracture, especially regarding the tuberosity. Particular attention should be paid to the medial calcar, of course, due to both its importance in maintaining the blood supply and the fracture stability. The plate should be sited inferior, and this is a very important item. And I think Mr. Bandy has mentioned it. The plate should be sited inferiorly enough to avoid post-operative impingement and superior enough to ensure correct placement of the head of the head screws. So it's not too much superior, so impingement will be present, and not too much inferior, so the screws will not be in an optimal direction. Articular penetration of these proximal screws should be avoided. Bone graft, either with an autograft or such as iliac bone graft, or fibrillar graft, as Mr. Bandy shown, bony allograft or bone substitute can aid to the stability of the overall construct and promote healing. Reduction of the tuberosity should not be overlooked in order to regain biomechanical advantages of the rotator cuff and increase the strength of the fixation. The age, as we said, is the most important item. Patients under the age of 60 years or those who sustain 2 or 3-part fractures tend to have an improved functional outcome compared to older age group with more comminuted fracture types. The major complications are screw penetration, AVN, implant failure, and impingement. Intramedullary nailing. Intramedullary nailing is a very important item, and for me, I reserve it for the 2-part surgical neck fractures. Results are significantly poorer in those with 3 or 4-part fractures. Some surgeons are reticent about intramedullary nailing in the younger patient due to reported rotator cuff damage, of course, and persistent shoulder pain. I can overcome this, minimize this by meticulous placement of the entry point, avoiding the footprint of the supraspinatus tendon. Ensuring the nail is well poured under the bone also helps to prevent post-operative discomfort and subsequent need for nail removal. Now I come to arthroplasty, and I will make a special concern regarding the arthroplasty and the difference between hemiarthroplasty and reverse shoulder. I think Mr. Bandy have mentioned, and I will make a special concern about some points and in this topic. The indications. Number 1, 4-part fractures and fracture dislocations. I have to have the proper indication to do and to go with arthroplasty. Number 1, 4-part fractures and fracture dislocation. High instance of avascular necrosis between 13 and 34%. Certain 4-part fractures in young patients in which the humeral head is in valgus position. This is a very important and may be amenable to internal fixation. 4-part fracture dislocation should be treated with prosthetic replacement. Conservative therapy results in only 5 to 15% satisfactory outcomes. reports of open reduction in internal fixation have shown a satisfactory outcome in approximately 30% of patients. However, satisfactory outcome was noted in 80% of patients with humeral head replacement. Three-part fractures and fracture dislocation in young individuals can often be treated adequately with open reduction and internal fixation. However, older patients with osteoporotic bone, I should go with hemiarthroplasty or reversed shoulder. Two-part anatomical neck fracture. And this is a very important topic, the anatomical neck fracture. In two-part anatomical neck fracture, prosthetic replacement should be considered when this fracture is encountered in elderly patients because the instance of AVN is very high in anatomical neck fractures. In impression fractures, prosthetic replacement has been shown to be the treatment of choice for lesions involving over 40% of the articular surface. And in head splitting fractures, open reduction and internal fixation may be tried in younger patients with a high rate of failure. And in older patients, I should go directly with replacement. Indications for hemiarthroplasty are narrow. The procedure is technically demanding and the construct relies heavily on the unpredictable healing of the tuberosity. The key success for the hemiarthroplasty is healing of the tuberosity. If the tuberosity do not heal, you have 100% instance of failure of hemiarthroplasty, and so you go forward to reversed shoulder. Hemiarthroplasty is best reserved for the young patient with an unreconstructable proximal humeral fractures. Failure and poor outcomes are associated with prosthesis height. This is a very important. Failure with prosthesis height overstuffing or humeral length increase by more than 10 millimeters. Humeral head retroversion by more than 40 millimeter, low greater tuberosity positioning, 10 millimeter inferior to the tangent line of the head, or high greater tuberosity positioning, 5 millimeter superior to the tangent line of the head. The optimum is 8 millimeter. Indications for reversed shoulder arthroplasty. Physiological age, more than 65 years old with rotator cuff tendinopathy, unreconstructable, highly displaced 3- and 4-part fracture, head splitting proximal humeral fractures, failed, of course, open reduction and internal fixation, or failed hemiarthroplasty, and symptomatic malunion or non-union. What are the contraindications? And this Dr. Pandey has mentioned: deltoid insufficiency, axillary nerve dysfunction, insufficient glenoid bone stock, active infection, and Charcot joint. This is a very important point to mention, the hurtle protectors of humeral head ischemia. This is a very important item because I have to expect this fracture is going to have AVN, so I should go directly to replacement, or I can try open reduction and internal fixation. Hurtle has made predictors of humeral head ischemia. The longer the length of the medial metaphyseal extension, more than 8 millimeters, the more likely the humeral head is perfused. And of course, integrity of the medial hinge at the pivot point of the dorsomedial fracture line predicts vascular perfusion and feasibility of reduction. So the two main important indicators is the length of the medial metaphyseal extensions and the integrity of the medial hinge. The prosthetic positioning, and this is a very important item if I'm expecting to have a good results after and excellent results after the replacement. How to adjust the prosthetic height and the prosthetic retroversion. Number one, how to adjust the prosthetic height. While I have many ways to adjust the prosthetic height. Number one, the assistant maintains gentle traction on the arm, and the surgeon uses a tool to lift the collar. As you see, I left the collar of the prosthesis so that the head of the prosthesis will face the level at the glenoid fossa. Number two, proper height of the prosthesis should allow anterior and posterior translation of approximately 50% And when the arm is pulled down, the humeral head should not fall below the midpoint of the glenoid. Number 3, the long head of the biceps tendon should have proper tension over the head when the prosthesis placed in a proper height. Number 4, and this is a very important thing to consider, the jigsaw puzzle technique. I preoperatively I assemble the fragments, and then after I assemble them as a puzzle, I put my prosthesis and then collect them on the prosthesis. The fracture fragment are reassembled to determine the proximal humeral anatomy, which is then precisely reconstructed with the prosthetic implant. This is usually there is usually a calcar gap of about 5 millimeter to 7 millimeter that must be recreated. Number 5, Moshopesky and colleagues, according to their cadaveric study, found that the distance from the top of the pectoralis major tendon to the articular surface averaged 5.6 centimeters, and this is a very important indicator. I have a very important way of measuring the height, the Gothic arch technique. Krishnan has developed that technique based on preoperative planning with X-rays of both humeri. First, the normal, and then the affected, the fractured one. For the unaffected extremity, the distance between the superior aspect of the humeral head and the transepicondylar axis is measured in centimeters along the prosthetic axis and corrected for magnification. Second, for the affected extremity, a line perpendicular to the prosthetic axis is drawn at the level of the fracture medially, and then medially, and then the level of the distance between the medial fracture line and the transepicondylar axis is measured. The residual, I calculate both of them, I subtract both of them. The residual humeral length is the actual length of the prosthesis. How to adjust the prosthetic version. This is a very important item. While traction is applied to the arm, as we see, while traction is applied to the arm in neutral rotation, the prosthesis is rotated posteriorly until the head of the prosthesis is facing directly into the glenoid fossa. This will correspond to 20 to 25 degrees of retroversion. A rongeur is used to make a notch in the anterior shaft of the humerus in direct line with the anterior fin of the prosthesis to ensure correct retroversion during implant fixation. The second method, while flexion of the head to 90 degrees and adjusting the transepicondylar axis of the elbow to 0 degree, the arm is externally rotated to about, as we see in the figure, externally rotated to about 20 to 30 degrees, where the humeral head points directly to the glenoid. For prosthesis with 3 fin, as you see the prosthesis with 3 fin here, the position of the lateral fin of the prosthesis approximately 5 to 10 millimeter posterior to the bicipital groove, with the anterior fin overlying the bicipital groove and aligned with the forearm in neutral rotation. However, the bicipital groove is not an accurate landmark. For prosthesis with version rods, the forearm axis is placed between 20 to 40 degrees adjustment rod, while the elbow is flexed to 90 degrees. What about the complications? And Mr. Bandi has mentioned the complications of the proximal humeral fractures. Number 1, AVN, of course, more common in comminuted fractures. Any associated dislocation also increases the risk of impairment of the blood supply. As previously mentioned, the anteromedial portion of the head is believed to be a critical area with regards to maintaining adequate blood supply. Number 2, non-union, infection, poor physiological reserve, smoking, diabetics, inadequate fracture stabilization, all are contributing factors. Number 3, malunion. The elderly population tend to cope with the malunion, but for the younger, the expectations will be higher, and so they cannot tolerate malunion. And number 4, stiffness. Stiffness has many, many reasons. Number 1, capsular tightness. Number 2, fracture malunion. Number 3, impingement secondary to plate misplacement, and cuff dysfunction also can contribute to a stiff shoulder. Thank you so much. I hope I have covered all the aspects regarding the proximal humeral fractures.
Thank you very much, Professor Al-Ashhab. That was very good presentation. You covered the topic fully. So we don't have any questions at the moment. I'll just ask maybe a couple of questions.
Yes, sir.
Just want to go through how you manage displaced, isolated, lesser tuberosity fracture and greater tuberosity fracture.
Yes, for both of them, if I can go with minimal percutaneous fixation and minimal percutaneous screw fixation, this will be good. I don't want to disturb the soft tissue because, as Mr. Bandi said, the AVN can be due to the geometry of the fracture, and of course, it can be iatrogenic. The soft tissue dissection induced by the surgery can go with the fracture to AVN. So if I can fix them with a minimal invasive techniques, so that will be good.
Okay. And both tuberosities displaced?
For both tuberosities displaced, if this displaced in older age with the expectations of this patient is not so much as have shown in the last case Mr. Bandi has shown, so I can manage them conservatively. But in younger patients, of course, I have to, if I can go with mini invasive, okay. If it's not properly reduced, I have to open and reduce them properly, because the key success thing for any kind of fracture is the proper positioning and the proper healing of the tuberosity.
Okay, that's great. Thank you. What is your rehabilitation protocol for these fractures after fixation?
Yes, after fixation, I make the patient in a sling, resting for 1 week up to 10 days. And then I start the pendulum exercises for about 2 weeks. And then I start the elevation and the wall exercises for about 1 month. And then I go, all these are active, no passive manipulation at all. After full healing, we can go to a passive manipulation if it's needed.
Right, okay. And for hemiarthroplasties?
For hemiarthroplasty, I do not do hemiarthroplasty too much because of the limited indications for hemiarthroplasty. But of course, for hemiarthroplasty, I do the rehabilitation immediately after maybe 2 to 3 days, the pendulum exercises. But I don't go at all with the active elevation exercises, waiting for healing of the tuberosities. Because healing of the tuberosities in the hemiarthroplasty is the keystone for success of this procedure. If I don't have a proper healing of the tuberosities, especially in hemiarthroplasty, so the only solution will be reverse suture.
Okay, thank you.
Thank you, sir.
I'm not sure if Mr. Pandey is online or if he has any input on these.
I think he's driving.
Yes.
Any other question, Dr. Srinivas?
We don't have any other questions on the from the listeners actually. So I think that will be all.
That's the end. Okay. Thank you so much, sir. Thank you so much for Mr. Bandi and for Ortho TV and for Eva Pharma Company. I think we have a question before we
yes,
close.
From Dr. Al Sultan Muhammad.
And when
you do shoulder arthrodesis and when?
I don't do shoulder arthrodesis in trauma, in fractures. I do it in cases of arthritic shoulders if the patient is not amenable for replacement. Mr. Bandi is with us.
Those with severe neurological injuries also may be candidates for brachial plexus injuries. Mr. Pandey?
I think he's trying to connect with us.
I think infected replacements is a completely different subject altogether, isn't it?
That's a disaster. Infected replacement is a disaster. I go directly, if I suspect infection, I go directly do debridement, thorough debridement. But if the infection persists, this is a very, very complicated case. I have to remove the prosthesis, waiting for the infection to subside, and do a two-stage revision. Or if the patient's old age, he can, with the musculature, can do some form of movements, and he doesn't want to make another revision. Mr. Bandi is with us. Mr. Bandi?
Yeah, I've been with you.
I want to ask you about your experience with infected prosthesis, sir. If it's not responding to antibiotics and not responding to debridement, and you have to remove the prosthesis.
Yeah, if there is infection, if it's acute infection within 4 weeks of your operation, then debridement works. If it is beyond that, 3 months, 4 months, I don't think there is any other solution than to do a 1-stage or 2-stage revision. It's a disaster. I think if you've done a hemi, then it is almost, you have to change it. Otherwise, it's a problem. But if you do a fixation with the plates and things, then I think you can retain it and clean it. But a prosthetic infection is a disaster in shoulder.
Yeah. Do you do, sir, 1-stage revision?
So 1-stage revision you do if you know the bug.
Yeah.
So if you know the the bacteria, and it's consistent, then you can do 1-stage revision. But if you don't, if you're not sure of the bacteria, then always 2-stage.
Yeah.
Because if you know the bacteria pre-op and there is no sinus, if there is a sinus, I will do 2-stage. If it's no sinus and I know the bacteria for sure that this is the bacteria which is growing, then 1 bacteria, not 5, but then I can do 1-stage. Because the problem, unlike hip, the shoulder is a joint which requires movement. And if you do more surgery, number of surgeries, the movements get affected.
Yes.
If you do, sir, 2-stage revision, you put a spacer in the interval between the 2 stages?
Absolutely, yes.
Yes. But in shoulder, you are not afraid of shortening like in hip. So the prosthesis, the spacer you put is a handmade spacer with a cement or a pre-made spacer. Sir?
Our managers get a commercially made ones, which is available.
Yeah.
And so I have at least 1 patient who I put this spacer inside, and now he doesn't want any more operation. He is happy with the spacer. He's moving his shoulder and he says, I don't want any more operation. Leave what is there inside. I'm happy with it. So I think sometimes you can get lucky with a patient who's happy with a spacer rather than a 2nd-stage revision.
But you cannot leave the spacer, sir, more than 3 months.
No, if it's a commercially made speaker, this guy is almost 3.5 years now. And he's still okay. Whenever I see him, I get depressed. But he says, no, I don't want an operation. I'm happy with this. I have function and I don't want to leave. I want to leave it.
Yeah. Unfortunately, it's not available in Egypt, the commercial made spacer in a shoulder replacement.
Yeah. So if you're handmade, then of course, I think you're probably better off moving it.
Yes. Thank you so much, sir.
Okay. That was a very nice talk. So can I ask you a question then?
Please, sir.
So is there, in your practice, is the role of hemiarthroplasty going down and reverse shoulder arthroplasty increasing?
No, I have one of my fellows with an MD thesis. Most of his cases regarding the hemiarthroplasty. Of course, we have cases with hemiarthroplasty, and in the developing countries, there's a huge difference between the cost of the hemiarthroplasty and reversed shoulder. So for the patients with selected patients that are suitable for hemiarthroplasty, I go directly for hemiarthroplasty. Some cases, the hemiarthroplasty lasts for more than 15 years with them. So that's good.
Yeah, that's good. Very good indeed. That's good.
Reverse is very expensive, actually. So
yeah,
here,
thank you very much.
Yeah.
Yes.
Thank you so much, Mr.
True.
Brandy. Thank you so much, sir.
Yeah, one day we should come and one day the Leicester team will come to Egypt and do a Leicester shoulder, inshallah.
Inshallah. Thank you so much, sir.
Yeah. So one day I will get in touch with you sometime, and then we can discuss that.
Thank you so much, sir. You have a very good football team, sir.
Not anymore.
Thank you so much, sir. Thank you so much for sharing your experience with us, sir. Thank you, sir. Have a nice time. Thank you so much, sir. Thank you, sir. Finally, I would like to thank Mr. Brandy for sharing his very long experience with us in this very fruitful session. Many thanks to my dear friend, Dr. Sernivas, for preparing for being sharing his experience with us, and also for being the moderator of the these webinars from the Indian side. Many thanks to Eva Pharma Company for sponsoring this course, and to Ortho TV for live streaming this course to all the Asian countries. Thank you so much, our dear colleagues and our dear attendees, and see you inshallah next Friday. Thank you so much, sir. Have a nice time. Thank you so much. Goodbye, sir. Thank you so much.